Welcome to VerifiedRx, your prescription for success. Brought to you by the Vizient Center for Pharmacy Practice Excellence.
Hello, and welcome to VerifiedRx. Today we explore the 2026 Centers for Medicare and Medicaid Services Annual Final Rule for the Outpatient Perspective Payment System, or OPPS. Most policies provided in the final rule go into effect on January 1st of 2026, but CMS is delaying enforcement of finalized hospital price transparency requirements until April 1st of 2026 to give hospitals additional time to comply. Joining us in this conversation is Jenna Stern, VP of Regulatory Affairs and Public Policy at Vizient. We'll cover changes to payment policies, payment rates, and quality provisions for Medicare patients who receive care at hospital outpatient departments or receive care at ambulatory surgical centers. I'm Carolyn Liptak, Pharmacy Executive Director in the Center for Pharmacy Practice Excellence at Vizient, and your program host. Welcome to the podcast, Jenna. It's great to have you back.
Great to be back, Carolyn.
The OPPS annual final rule sets how Medicare pays hospitals for most outpatient services in the coming year. It's issued annually, typically published in November, effective January 1st, and includes payment rates, policies, quality programs, and compliance rules. Jenna, can you share with us some key takeaways from the 2026 final rule?
Absolutely. So there was a lot in the Outpatient Perspective Payment System final rule for 2026, and this rule is currently in effect. And I think that's, of course, one of the key takeaways. In addition to the hundreds of pages to sift through, it can be hard to sift to decide a specific policy or proposal that members should be most aware of. But I think some of the key takeaways are that hospitals will continue to face financial pressures ahead, given the modest rate increase and other key policy changes that reduce reimbursement. Things like site-neutral payment policy, for example, will be particularly impactful from a financial perspective. In addition, one other key takeaway from this final rule is that we're starting to see more of the administration's priorities take shape, and we see those priorities coming through in different policies that have been finalized.
Thanks, Jenna. Let's go ahead and dig into the final rule. For calendar year 2026, CMS finalized policy to apply an OPD schedule increase factor of 2.6%, except for those hospitals not meeting certain quality reporting. What does that mean for hospitals, and what can they expect?
Overall, the 2.6% increase factor is fairly modest. So it again goes back to that idea that hospitals will continue to face financial pressure in 2026. The 2.6% amount itself was determined by a 3.3% hospital market basket increase, and that amount is then reduced by a 0.7% productivity adjustment. So this is meant to capture things like increases in productivity or inflation, so things that can really impact what a hospital is spending and the cost of care. Overall, only a 2.6% increase is provided after accounting for all those changes. That being said, this is slightly better than the proposed rule, which included a 2.4% increase factor. And based on this update, CMS estimates that the total 2026 payments to OPPS providers will increase by about $8 billion for 2026 when compared to the 2025 payment levels. So while it's not as high as we would like to see, it certainly is not negative, and that's better than nothing.
It is a tiny bit of good news. From 2018 through September of 2022, CMS reimbursed for certain 340B drugs under OPPS at ASP, average sales price, minus 22.5%. And they did this while increasing payments for non-drug items and services to keep the policy budget neutral. But then in June of 2022, the Supreme Court ruled that CMS couldn't set different payment rates for 340B drugs without first surveying hospitals' acquisition costs. Jenna, what's new in this year's final rule around the 340B remedy offset?
This is a really critical part of the final rule. It goes back to that idea of some of the financial pressures that hospitals should be anticipating for the year ahead and beyond. Overall, in the final rule and in the proposed rule, CMS had considered making policy changes to their previously finalized remedy offset. This remedy offset was finalized in response to the Supreme Court decision to overturn their previous policy for 340B acquired medication reimbursement. Ultimately, CMS in this proposed rule thought about increasing the remedy offset from 0.5% per year to upwards of 2%. So that would be a 2% reduction that CMS was considering applying for OPPS providers. That's important because financial pressures that hospitals are enduring, this would be a very substantial impact to them if CMS were to increase that in the span of 30 days or so since we got the OPPS final rule out late this year. The good news in this final rule was that stakeholders commented and opposed CMS significantly increasing this remedy offset to 2%. And CMS agreed with stakeholder comments that the timing was just too quick and that this would be a significant burden on hospitals if CMS were to finalize that 2% remedy offset. So CMS ultimately did keep the 0.5% reduction, which again, that's controversial in and of itself, but CMS did indicate for 2027 that hospitals should anticipate a larger offset adjustment to be proposed through that rulemaking cycle. This is an area where we see some good news of CMS not finalizing a more substantial reduction, but another area that providers should be aware of because this remedy offset is the first year that it will be in effect for 2026, and that can impact providers' bottom lines.
Thanks, Jenna. You mentioned site-neutral payments in the key takeaways. Site-neutral payments is a topic that a lot of people are talking about. We see more on this in the new rule. What does this policy mean, and what exactly did CMS do in the final rule?
At a very high level, site-neutral payment policy is a general idea that if a service is provided in different settings, so a lower cost setting like a doctor's office or a higher cost setting like a hospital outpatient department, then the reimbursement rate for those services should be the same. That sounds like a good talking point, but when you drill down to the impacts of this policy and what this would mean for providers is that it tends to ignore the standard payment system frameworks that exist, doesn't acknowledge differences between sites of care, different things that are occurring between these sites of care that could justify that care being more costly, and it can also not adequately account for patient acuity, among other concerns. So generally, from a hospital perspective, site-neutral payment policy can be very concerning because it's not increasing hospital rates, it's decreasing them down to a physician's office or other site of care, for example. If we think about this and then look at the 2026 OPPS final rule, CMS finalized a policy to expand their existing site-neutral policy for accepted off-campus provider-based departments by including a broader scope of services. So CMS finalized including drug administration services in the scope of services that would be subject to site-neutral payments. As a result, services provided at these locations, their reimbursement rates will be more consistent with rates that are provided under the physician fee schedule. So that represents a substantial cut. To put this in a little bit more context in terms of just how substantial a cut this would be, CMS expects that this will reduce outpatient spending by about $290 million for 2026 alone. Of that, $220 million of those savings will accrue directly to Medicare. And that's important to be aware of because this policy isn't being implemented in a budget neutral manner where reductions in reimbursement in one area is redistributed to another area. So overall, less money is being spent that would otherwise have been paid out to hospitals because of this policy.
So definitely now a little bit of bad news.
Definitely.
Temporary additional payments to hospital outpatient departments for non-opioid treatment for pain relief began on January 1st of 2025. Why is CMS making these payments, and is there anything new for 2026?
To think about these payments, it's important to be aware of some of the statutory context. So back in December of 2022, the No Pain Act, or Non-Opioids Prevent Addiction in the Nation Act, was signed into law because it was included in the Consolidated Appropriations Act of 2023. The law effectively provided that beginning January 1, 2025, CMS would separately pay for non-opioid treatments, such as drugs, biologics, devices that meet certain requirements related to pain relief. So not all non-opioid products are necessarily eligible for these payments. Currently, separate payment is available under the law until December 31st, 2027, but to implement the law itself, CMS has to work out the details for the No Pain Act and identify how best to identify products, for example, so that this law can be effectively implemented. For 2026, CMS finalized that 5 drugs and 13 medical devices would qualify as non-opioid treatments for pain relief and that these will receive separate reimbursement in the HOPD or ambulatory surgical center settings. If you'd like to take a look at the final rule, those who are very interested in reading, Table 134 of the final rule lists out all the qualifying products if you're interested in taking a closer look. Now, one other area I would note in the final rule is that CMS had actually made a modification to permit more timely consideration of payment requests in response to stakeholder comments. So CMS provided that it would be reasonable for the agency to consider a pathway to approve new products on a more frequent basis. So moving away from a solely annual basis to identify products. Ultimately, the quality criteria is not changing, but the frequency in which CMS can approve qualifying non-opioid treatments for pain relief is what's changing. Shortly after the rule was finalized, CMS released some guidance outlining how to alert and engage with CMS regarding these new opportunities to qualify for these non-opioid treatments for pain relief. I'm really curious to see how this change impacts the scope of products that are eligible for separate payment in the future. But I think this is one change to flag that didn't necessarily receive a ton of airtime, but is no less important to be aware of.
We've all been interested in this topic as well. And one thing to note, the 5 drugs that were finalized for 2026 are the same 5 drugs that were finalized in 2025. There wasn't any additions.
Right. That's potentially a good reason why CMS is revisiting the frequency that they're updating this list and giving stakeholders more of an opportunity to be included on the list so it can have more of an impact.
And we'll be sure to put that list in the show notes. Also, in the 2026 final rule, CMS finalized the agency's intent to conduct a survey of the acquisition costs for each separately payable drug acquired by all hospitals paid under OPPS, subject to some clarifications and modifications that are discussed in the final rule. Jenna, why do you think CMS is advancing this survey now?
This is certainly a hot topic. CMS had previously advanced a policy to provide a different reimbursement rate for 340B acquired medications. And that policy was advanced without CMS surveying hospitals, so did not pass muster with the Supreme Court. So that was that ASP minus 22.5% policy back from 2018. Thinking of that with some of the background that CMS already has an interest in trying to change reimbursement rate for products, knowing that the Supreme Court directed CMS to have some kind of survey data before advancing such a policy in the future. We also see some of the administration's priorities coming through here as well. On April 15th, there was an executive order from the White House on lowering drug prices. And within this executive order back in the spring, HHS was directed to publish a plan to conduct a drug acquisition cost survey. And following conclusion of that survey, requested that HHS consider proposing adjustments that align Medicare payment rates with the acquisition cost. So CMS also makes points similar to these in the final rule when it's talking about why it is advancing this survey. And the timing is very important here because this sets up the agency well to use the survey data, which should be collected in the first chunk of this year, and use that information to inform rulemaking for 2027. So this is not the last we'll hear about the survey by any means, but really gearing up for 2027 rulemaking and policy related to use of the survey data for them.
Okay. Every year, CMS sets a packaging threshold for medications and radiopharmaceuticals administered in the outpatient setting. Are there any changes to the thresholds for 2026?
There are some changes this year. So for drugs and biologics, CMS is keeping that packaging threshold at $140. So that's the same as 2025. One change, though, is for high-cost diagnostic radiopharmaceuticals. CMS provides a slight increase up to $655, so up from $630 in 2025. HCPCS codes for the products at or below the threshold retain their status indicator N, meaning their payment remains packaged with the associated service.
This information is good to know because I often get questions about this. So status indicator N drugs may seem less important because they aren't separately payable and as a result are sometimes overlooked when it comes to billing. Some feel that it may not be necessary to bill for them since they're not separately paid. But just because they aren't separately payable doesn't mean they're not covered, and hospitals are required to bill for them, specifically because the calculation for the bundled payment that does cover these drugs comes from each hospital's cost report, and if they aren't billed, then they won't be included in the bundled payment going forward, and the bundled payment could be inaccurately low.
I agree completely. It's important to be aware of these and to always track everything.
Yeah, you bill for them anyway. So also for calendar year 2026 and subsequent years, CMS finalized eliminating the inpatient-only list through a 3-year transition, completing the elimination by January 1st of 2029. Why is this change so important?
This is another critical change that sounds like policy we've seen before. This was a policy that was proposed in the first Trump administration, but never ultimately implemented. This policy is critical because as we think about where care is currently being provided and covered by Medicare, the inpatient-only list helps ensure that certain services are provided on an inpatient basis only. So the name is very descriptive of what it is. This can help protect beneficiaries and ensure that they're receiving services on that inpatient basis because that's the safest place for those services to be provided. And there is a set of criteria that CMS had before to identify which services should be maintained on the inpatient-only list. With the phased elimination of the inpatient-only list, CMS emphasizes that practitioner judgment is going to be critical in determining the appropriate site of care. But this could ultimately result in more patients receiving procedures that have typically been viewed as riskier on an outpatient basis rather than an inpatient basis. So whether that truly plays out still remains to be seen at this point, but that's one important potential impact of this policy change. In addition to that, during the comment period, several hospitals voiced concern about this proposal, noting, of course, those patient safety concerns, and also that payers may change coverage policies in ways that suggest that certain services should be provided on an outpatient basis rather than an inpatient basis. So making the assumption that these services are always safe to provide on an outpatient basis, which is not always true. So we don't entirely know how payers will respond either. It's still early. This rule just went into effect, but that was one of the concerns that many stakeholders raised as this proposal was being considered. One of the other pieces that complements this policy proposal was that CMS also changed their policies related to the ASC covered procedure list and rapidly expanded that list to include several of the services that were removed from the inpatient-only list. So we see a significant expansion of the ASC covered procedures list. So there could be, again, an opportunity for more patients to be seen not only in an outpatient setting, but also by an ASC. It still remains to be seen how this will play out, but it opens the door to patients receiving care in settings that we may not have seen them receiving that care in before.
Yeah, it's certainly something to watch. So another topic that's been around for a while is price transparency. It shows up again in the 2026 final rule. Are there any key takeaways this time around?
Yes, absolutely. The key takeaway is that price transparency is not going anywhere. So we did not see a wholesale change to price transparency regulations. Overall, we see the administration's ongoing interest in advancing price transparency policy, and there's more refinements within this final rule. In addition, we start to see CMS considering different opportunities to use price transparency data. This is something to anticipate in future rulemaking and for stakeholders to keep an eye on as CMS is looking to use the data for purposes other than what we typically think of price transparency data being used for, which is patients trying to compare rates for services at different hospitals. That's really important to be aware of, just these different uses of price transparency data moving forward.
Jenna, all of this information is incredibly helpful. What do you think are the most critical policies for our listeners to be aware of?
It is a lot, and I hope it was helpful information. Again, I know OPPS is very long, but I think the ones that really jump out to me are the payment rates overall, that modest increase, site-neutral payment policy for drug administration services, the 340B remedy offset, the drug acquisition cost survey, even though we don't necessarily have any rulemaking in place for 2027 yet. That will be important to watch moving forward. And I'm talking about regulations today and really focusing on OPPS, but there was a lot of other regulatory activity towards the end of 2025, and we are actively following that activity as well. So while we're not necessarily going into a deep dive on those other innovation center models, for example, those are other topics that are also top of mind for us.
Thanks, Jenna. Is there anything else that you think we should know?
Last but not least, I always like to do a plug for resources. We do have an OPPS final rule summary available on our government relations and public policy page. That's easily accessible and will give you a little bit more information about the contents of the outpatient rule. And we'll touch on some of those other topics that I may not have touched on today. In addition to that, we have other resources there, a globe model summary and our comment letters to CMS.
Thank you, Jenna, for joining us today to share your thoughts and insights and help us understand this complicated rule. It's been really great chatting with you.
Great. Thank you so much for having me, Carolyn.
Subscribe today. Like us. Send us your comments. We'd love to hear from you. VerifiedRx is a prescription for success and is brought to you by the Vizient Center for Pharmacy Practice Excellence. Thanks for listening.